Assalamu alaikum everyone. Welcome to the neurosurgical case room and belated Eid Mubarak. Let's start where we left off before the Eid holidays. And I believe we did just before the presentation of the falx meningiomas. And I initially was planning to finish off this topic today because the surgical steps are more or less similar. There were only a few differences from the approach that we use for parasagittal meningioma, the interhemispheric approach. So I initially was planning to finish this up, but as it happens, there were a few other interesting things that came up and I wanted to discuss. So without any further ado, let's begin. We did discuss this yesterday that we can divide these. In fact, let's go back to this slide. We divide the falcine meningiomas just as we divide the parasagittal meningiomas, the anterior ones, the middle ones, and the posterior ones. I am audible, right?
Yes.
Yes, we can
Thank you.
hear you.
Thank you.
Thank you.
So let's start in pointer. We divide them the same way as the parasagittal meningiomas. We have this A category, the B category, and the C category. The division is from crista galli to coronal suture, and from coronal suture to lambdoid suture, from lambdoid suture to the torcula. What ends up happening is the only difference is this parasagittal meningiomas, they usually involve the superior sagittal sinus here, which is right at the topmost border, whereas the falcine meningiomas can have the propensity to involve the superior sagittal sinus here, but it can also involve, if it is growing inferiorly, it can also involve the inferior sagittal sinus, which is running in the free border of the falx. We did discuss the anatomy, right? Apart from that, if it is something which is, if it is completely anterior, if it is here and this ends up growing a big lesion, so there can be direct compression over the ACA-ACOM complex, etc., etc. Whereas if the lesion is growing here, there can be very direct compression over the corpus callosum, or sometimes the third ventricle, the lateral ventricle, depending on whether this is in the anterior middle third or the posterior middle third. So please remember that we are still in the middle third space, middle third presentation, but it can still be divided into the anterior and the posterior. Then when we talk about the posterior third falcine meningiomas, there can be involvement of the occipital cortex, but if the lesion is slightly inferior, then it can cause direct compression over splenium. It can involve the pineal region lesions and the pineal region structures. It can all, if it is slightly posterior around here, it can also involve the torcula, and whereas there's a specific category. Let me write this: focotentorial meningiomas. So if this is the tent, this is the border, tentorium cerebelli, and if this lesion grows big enough, so it can involve at this point the tent and the falx both, and in the worst case scenario, also engulfing the torcula, which is posterior. So a lot of times the classifications that we are looking at, they are more for our own understanding rather than, very strict classifications that we have to have, because during the falcine meningiomas you will find some overlap with the focotentorial meningiomas. There will be some overlap with the parasagittal meningiomas. So always remember this, that there is no hard and fast rule. We study classifications in order to get some help during the surgical planning. The only reason they exist is because we want to have a good plan. For example, if this is a falcine meningioma here, which is primarily originating from the falx, But later on, it is also involving some wall of the superior sagittal sinus. We should know that beforehand so that, we can go in prepared if there is any plan of resection of the sinus wall, etc., etc. So let me move on. Am I clear, or was this all too fast?
Clear.
Okay, let's move on. Presentation is really easy for you to understand, hopefully, inshallah, because we have done these very thoroughly with the parasocial meningiomas as well. They are very similar. Patients with the anterior third lesions, they usually have this insidious mental decline. They will have personality changes. They will have cognitive impairments, including some amnesia. Patients can also have, sometimes they can have this urinary incontinence as well. This inhibition can be a feature, excessive gambling, etc., etc. Then you can also have the elevated ICP. Headaches can be there, blurred vision can be there, papilledema, etc. Seizures for the interior third are rare comparatively because usually before cortical irritation occurs, the lesion grows big enough and it's identified for some other symptoms. But they can occur, and if they do, there can be speech arrest. Moving on, let's take a look at an image. This is a very simple, straightforward anterior falcine meningioma. You can see that it is originating from the falx here. And let me clear this. The dural tail is not as visible, but the falx is slightly more hyperintense in comparison with the other dura anywhere else. Apart from that, you can also see this clear space between the superior sagittal sinus here, which is here, and this parasagittal angle, which is completely free at this point. And the first definition, the first classification for falcine meningioma was given by Cushing and Eisenhardt, and they initially proposed that this space should be free. This space. Um, I have forgotten the particular term they used for it, but this space should be free and the superior sagittal sinus should be free. So later on, the Yasogil and etc. etc. There were a lot of other very notorious authors. They gave other classifications which now involve the superior sagittal sinus involvement as well, because from clinical perspective it can be really difficult to completely separate them as a hard and fast rule. This is more of a typical meningioma for the anterior third. Can somebody volunteer for the radiology?
Uh, Dr. Kaval, can I
Yes,
try?
you can, Dr. Sana.
Okay. Image A is an T1 with contrast, axial section showing an lesion in the interior cranial fossa with a heterogeneous contrast enhancement with the compression on the ventricles. And the image B is a sagittal section and for the similar lesion and causing the frontal lobe compression as well. And the other one is the coronal section of that same image, same lesion.
Okay. Do you want to make any other comment?
Mm, um, no, sorry.
Okay. Will this technically be considered as an anterior skull base lesion because it is not arising from skull base? Do
No,
you yes? Do you see there is
inferior.
this rim of the cortex here?
Yes,
There
yes.
is a rim of the cortex, so it's not arising from the skull base. Apart from that, do you see the dural tail originating that it might be arising from the falx?
Yes.
Apart from that, there is another important feature. It is causing direct compression over the corpus callosum. If you look at the first image, you can see that there is direct compression over the corpus callosum. The lateral ventricles are effaced slightly. Apart from that, the meningioma is crossing the midline. The falx has been shifted towards the other side. There is a midline shift, and the falx is Okay, somebody is writing in the chat box. Whoever this is, yes, you are right. More or less, there is this midline shift. There are these intralesional cysts that you're talking about. Please leave me your name in the chat box. It was an excellent answer. And if this was T2 weighted image, you would probably have been able to see the significant perilesional edema because we can see some hypointensity here. But that's okay. It's okay if you don't comment on it. But the heterogeneous intensity and the solid cystic appearance, which could be necrotic areas as well, that is important to comment on. Also, never say skull base if it is not clearly arising from the skull base. This is the middle third lesion. Yes, Dr. Fatma, I knew the answer was from you. So we have the middle third lesions. They are the most frequent cytopharism for Falcine Meningiomas. And why is that important for us? Because we know if we have the supplementary motor area, we have the primary sensory motor cortex, and especially, what did we discuss was on the medial side? What is the medial continuation of the primary sensory motor cortex? Can somebody name it?
Paracentral lobule.
That's right, Dr. Sana. This is paracentral lobule. We discussed it. That paracentral lobule is the medial continuation of the primary sensory motor cortex along with the central sulcus. So, when we are talking about the middle third, it's not a good situation for the patient or for the surgeon because this is a high stakes surgery and you have to be very careful. The good thing with the supplementary motor area deficits is they are usually temporary. We have discussed this before. They are usually temporary because the representation is bilateral. Even if one side, even if a single sided supplementary motor area gets damaged during the surgery or due to edema or due to tumor factors, the other side will end up taking its function because this is a temporary deficit. With the primary sensory motor cortex, we do not get this insurance policy. So, with that, we have to be careful. Also, since this is a medial portion, what are the deficits that we will be expecting? Remember, we have genitalia. If you all remember the homunculus, we have the foot, the leg, the knee, the lower limb, basically, the lower extremities along with the genitalia. So, since this is a falcine meningioma, there will be a direct compression over this region, and patient can have particular focal deficit involving this area. It could be motor, it could be sensory, depending on where the lesion exactly is. Apart from that, uh, if the lesion is large or if there is significant perilesional edema, you can have some mixed picture, and there can be involvement of other areas as well. Patient can have generalized cognitive decline. If there is significant pressure on the corpus callosum, then that can include some left-right dissociation and some speech problems, etc. Depending on how big is the lesion, how huge is the perilesional edema, and where exactly in the middle third the lesion was. Am I clear?
Yes.
Okay, moving on. This is a very easy to understand stereotypical parafalcine lesion, which probably will also involve some level of superior sagittal sinus. This lesion could easily have been here as well, arising from the inferior portion of the falx. And if it arises here, then instead of superior sagittal sinus, we will be worrying about the inferior sagittal sinus. And if this is slightly posterior, if this is here, then we will also be worrying about vein of Galen plus straight sinus. Let's move on to the next image. Now, coming back Am I audible?
Yes.
I think I lost the signal for a very brief moment. Let me get back to the slide. Okay, coming back to this image. In fact, let's move on. We are short in time. It's already 7:50. You can see this image and you can also appreciate how deeply involving this is the superior sagittal sinus. You cannot even see the lateral wall on the affected side. So there will be a very small demarcation on tumors like these, whether they should be considered as parasagittal meningiomas or parafalcine meningiomas, because they're just as much on the convexity as on the falx, and we don't get to see a very significant dural tail, and there is some superior sagittal sinus involvement. We are going to discuss this in the classification later on. Let me clear this. What do you think of this image? Can somebody comment? Even if it's completely okay if you don't read it in entirety, just comment. What do you think this is? Okay, Dr. Fatma is saying this is an intraventricular meningioma. Um, you can
Falcine
justify that.
Meningioma involving
Yes,
the inferior sagittal sinus
yes, and there is a
and
particular
compression of the
type.
bilateral occipital horn of lateral ventricle.
That's right. So this is an extra-axial lesion and it is not intraventricular, Dr. Fatma, even though it could be passed off as an intraventricular lesion from a single section. So I get where you are coming from. But this is because I saw the entire image. This is a butterfly or bilobed falcine meningioma, a very specific type where the meningioma crosses the midline and it is on both sides of the falx, hangs down like a ball or like an apple or a butterfly something, and these tumors are classified in a different way. This is a neuroclassification 2017 something. I have linked down the article. Let's get to another image. It's a similar bilobed butterfly type falcine meningioma. And in this, you can see that this looks extraaxial. This is not intraaxial and it is not intraventricular. This is another image, slightly more anterior from the lesion that we looked at previously. And you can see some perilesional edema on the T2 weighted images. You can also see some phlovoids around the lesion. We are not sure whether these are tumor feeders or these are normal DACA, the distal anterior cerebral artery, which is disrupted or displaced. Apart from that, you can now appreciate that, as Dr. Nikit said, this is hanging from the inferior leaf of the falx. Let me clear this so that you can see. And the inferior sagittal sinus is completely engulfed. I'm going to draw this with a blue dot so that you can see the location of the probable location of the inferior sagittal sinus. Obviously, we can't be sure without an angiography here. So these were two atypical radiological images that I wanted to discuss, and let's move on. Then we have posterior third lesions. There will be compression of the visual cortex. There can be homonymous hemianopia with or without macular sparing. There can be some involvement of the falx along with the tentorium cerebelli, the junction of them, and sometimes even the toricula. If you look at this particular meningioma, this is more of a focotentorial meningioma group, which is also completely involving this inferior portion. Along with that, I would be very interested to see the angiography here to see if there's some involvement of toricula, because we can see, let me clear this and change the tip, you can see that there is some level of cortex remaining here on the backside of the tumor, but we cannot be sure if torricula is involved. Along with that, the other thing that I would be worried about is the straight sinus. So posterior third can be like this, but posterior third can also be like this. Posterior third can also be like this. So these are just two other alternate presentations. Are we all on the same page?
Yes.
Okay. So have you seen this classification before? Okay. I'll leave the link of the article. It's a paid article, see if you can get access to it. But the image is pretty self-explanatory. Let's get down to it. You can see type 1A, then you have type 1B, then you have type 2, then you have 3A, 3B, 3C. 1A is simple, our usual Falcine Meningioma, which is it's away from the superior sagittal sinus here. So there is some cortex in between and it's still on the one side. There is no midline shift. Okay, so there are two main uh, qualifying factors here for it to be called as type 1A. It is unilateral and there is no involvement of the superior sagittal sinus and there is no midline shift. This would be type 1A. Are you all clear on this?
Yes.
Then we have type 1B. For type 1B, we have midline shift, or at least the fox is being pushed to the other side. Apart from that, yes, I think that's it. You will see fox being pushed towards this side. This will still be a unilateral. Let me write it here. This will still be a unilateral meningioma. It will not go on the other side, only the fox will be shifted to the other side. So both of these are type 1. When we do not have midline shift, it's a type 1A. When we have a midline shift, it's a type 1B. Are we all clear?
Yes.
Then we have type 2. For type 2, you will have a unilateral lesion, but it will involve at least some portion of the superior sagittal sinus. Interestingly, if you zoom into this image, you can see, I'm going to draw there, a very small layer of cortex, which is still separating it from the topmost layer. Let me clear this. I'm sure you can see where my yellow arrow was, but there is some involvement of the lateral portion of superior sagittal sinus on the same side. So type 2 is still on one side and there is some involvement of superior sagittal sinus. This is midline shift. This is no midline shift and no superior sagittal sinus involvement. When we write all this, we have this in the text ahead, but let me be clear. Then we have type 3. Type 3 are these bilobed falcine meningiomas. They are bilobed or they look like a butterfly. They look as if they're hanging from the fox. 3A does not involve the superior sagittal sinus. You can see some fox here in the yellow color. 3B, there will be involvement of superior sagittal sinus, but only on one side. Let me clear this. If you look at this lesion goes slightly asymmetrical. There is more involvement of, this will be my left side. Yes, there is more involvement on the left side, and you can see some involvement of the lateral wall of superior sagittal sinus. So basically, 2 and 3B, they share the same feature. There is some involvement of superior sagittal sinus. For 3, it is a bilobed tumor. For 2, it is a unilateral tumor. 3C is different. 3C behaves completely different. It hangs from the inferior margin of the falx, and there is encasement of inferior sagittal sinus usually. It sort of hangs like a pear. Are we all clear on this? Should I go to the text?
Yes.
Okay. So this is a classification by Das, and it was a beautiful article. It was published in 2017. This is the link of the article. It's available on Science Direct. The classification is same, the one that I discussed. Type 1 is unilateral. They're entirely on one side. 1A has falx visible superiorly, and there is no midline shift. 1B is there's falx visible, but there's significant shift of falx to the opposite hemisphere. Let's move to the next one. Type 2, we have this lateral wall and the sinus involvement. Tumors are still unilateral. We discerned that from our picture, but there will be superior sagittal sinus involvement on one portion. Let me clear this. Type 3 are the bilateral tumors or the bilobed tumors. 3A are tumors in which you can still see the falx between the tumor and the superior sagittal sinus. So there is no significant involvement of the superior sagittal sinus. Dr. Fatma, I am not sure if it is by Zuo et al. I think it is by Das, but it could be, I think, a citation error as well. I have linked down the article for clarity. Then we have type 3B. Type 3B is a one-sided tumor that has extended along and invaded the lateral wall of the superior sagittal sinus, and you can all see falx in between. Type 3C is when it seems to hang like a pier or like a ball from the lower free edge of the falx. It directly compresses over the corpus callosum. There can be involvement of the inferior sagittal sinus as well. On rare occasions, sometimes falcine meningiomas can present with apoplexy, with sudden intratumoral hemorrhage, sometimes with subdural hemorrhage or due to subarachnoid hemorrhage. So these are rare presentations. I could not find good pictures, so I did not include them. But these have been reported in the literature. Investigations, you all know, we need an MRI brain with contrast. We need a DSA if there is suspicious involvement of major vessels, and you think a CTA or MRA will not suffice. And let me see. Usually a CTA or MRA, MRV would be okay. You need an MRA to identify if there is any involvement or displacement of ACA and the ACOM or the DACA. You would need the MRV, obviously, to figure out if any sinuses are involved. DSA is a really good adjunct if you are suspecting the involvement of vein of Galen, the inferior sagittal sinus, or the straight sinus, or if in worst case scenarios, patient have some torcular involvement. So in these situations, DSA would be really, really valuable because you would be able to identify any vascular encasement, etc. So intraoperative adjuncts, I'm sure you all know that we are going to need neuronavigation in the centers where we do not have neuronavigation. We will need at least an intraop ultrasound, or intraop MRI is not available everywhere. I get that, but intraop ultrasound is an easily accessible thing. You would need that because falcine meningiomas, until unless they are huge, they are not going to be visible from as soon as we open up the dural flap, which is in contrast with the parasagittal meningiomas. You remember we were opening up the bone flap, we were taking over the dura, and we could see the lesion for parasagittal meningiomas. Falcine meningiomas are deep down. For us to identify reliably, you would need some form of navigation. Apart from that, intraoperative neuromonitoring and cortical mapping, especially if you are in the middle third and you're working around the primary sensory motor cortex, QSA is a good adjunct. But if it is a fibrous meningioma, you would need scissors or whatever, to get the lesion out. So there is another interesting thing that I came across when I first read about falcine meningiomas in the textbooks. I don't see this getting discussed often. So I thought to include this. What do you know about the trigeminocardic reflex? Can somebody volunteer, please? I'm audible, right?
Yes.
Okay. So, yes, Dr. Fatma is saying heart rate and BP drop. That's right. So, trigeminocardic reflex is something we as surgeons need to be aware of, and we need to give our anesthetist a heads up as well. It is not a common presentation or a common surgical complication, but it is something we should know before we are proceeding for the surgery. Let's see what this is. Let's move on. Since it's a reflex, obviously there is going to be a pathway. Trigeminocardic. Trigeminocardic means there is going to be some component of trigeminal nerve, and there is going to be some component of cardiac system. We don't know yet, right? The efferent pathway is, we know, cranial nerve 5. Why? Because trigeminal nerve heavily innervates the falx, and it is also very, very sensitive. It's just as sensitive in some books as vagus in terms of parasympathetic stimulation. So what ends up happening is if you trigger the trigeminal nerve, you have the risk of triggering the parasympathetic system really, really heavily. And what that could do is it could lead to vagal activation. And due to vagal activation, patient can have significant bradycardia, etc., etc. So if we will look at it one by one. Fox is innervated by trigeminal nerve. When we are operating, and if we are rough with our handling of the tissue, if we pull on the fox, if we tug on the fox, or we use excessive bipolar on the fox, we can trigger this reflex. Clear this. How it works: the trigeminal, the branches, they carry it back to the Gazerian ganglion. From that, it goes to the brainstem, and from the brainstem, it goes to the dorsal motor nucleus of the vagus nerve, which is our parasympathetic dawn, or gang, whatever you want to say. So what it does is it slows the heart rate, and it even can put the patient in a cardiopulmonary arrest. So smooth. The efferent pathway is same. It goes via the vagus nerve. Remember that the efferent pathway went through the trigeminal nerve. The efferent goes through the vagus nerve and can slow down or completely stop the heart's electrical conduction. We discussed the triggers. The triggers are mechanical traction, pulling, dissecting, mobilizing. This usually happens when we are in the terminal stage of surgery, and if we think we can get away with doing it, or if we are very aggressive with the bipolar cauterization, or if there is heavy bleeding and we are blindly coagulating everything, that can trigger this reflex. And because it can trigger this reflex, our anesthetist should be on watch, and they should be able to alert us if the heart rate is dropping. And if that ends up happening, what's the best course of action? Anesthetist is going to handle it the way they handle it, but we also need to stop the trigger. If you keep on pulling, if you keep on giving the mechanical triggers or the thermal triggers, the reflex will keep up, it will keep happening. For the reflex to stop, you need to stop. And apart from that, obviously atropine can be given, etc., by the anesthetist to maintain the pressures. Yes, we would need anticholinergic and stop the surgery for a bit. That's right, Dr. Fatma. This was a brilliant answer. That's it for today. We will continue this tomorrow. Let's see, inshallah, if I can squeeze this in, the surgical management. It won't take long, probably 30 minutes at most, inshallah. So to be continued tomorrow. Any feedback, any questions, they're all welcome. If you think of any questions later on, you can leave that on the WhatsApp group. I hope you found it just as interesting as I did. Thank you so much.